Hello, my name is Cheryl Strong, and I'm part of the Skoll Foundation team. I'm very excited to welcome you to the Skoll World Forum session, How Radical Collaboration is Beating Back COVID-19. This year, the forum's theme is Closing the Distance, and we thought there was no better way to reflect that theme than to invite our global network to design and build a new kind of event together. I would like to share a few quick items before we log in. And the session is being recorded and will be released publicly after the event. Please feel free to use the chat to engage with each other and ask questions of the speakers. The session is scheduled to end in 60 minutes. After the session, please take a few moments to complete the single question feedback survey in the poll tab to the right of the video screen. On social media, we're using the hashtag SkollWF and would love for you to do the same. We are so thrilled to be able to include this session in this year's virtual Skoll World Forum and want to extend a special thank you to Community Health Impact Coalition for proposing and designing it. With that, I'd like to introduce Dr. Madeline Ballard.
Thanks so much, Cheryl, and thank you all who are joining this session in the midst of what continues to be a profoundly urgent moment. We're so glad that you're here. My name is Madeline Ballard, and I direct the Community Health Impact Coalition, which is a team of health organizations working in over 40 countries who've come together to make professionalized community health workers a norm worldwide. Today, we're going to be talking to you about what that means and how we've accomplished it. So when we say professionalization, we mean making sure that lay people who are trained to provide health services in their communities are equipped, supported, and paid to do so. We mean embracing common sense approaches to, like providing pay, continuous training, and coaching to these workers that help community health workers and therefore community health worker programs reach their full potential. Because while these practices that you see up on the screen right now are backed by evidence and codified in multiple sources, they nonetheless remain sporadically taken up, which is the status quo that we won't stand for. So as a coalition, as a team of organizations working in over 40 countries, we conduct research and advocacy to promote adoption of these design principles, these common sense approaches to implementation by stakeholders responsible for policymaking, financing, and implementing community health worker programs across the globe. What this looks like is everything from pooling data across countries to help identify practices that lead to quality care, to developing tools that make it easy for others to adopt those practices. But in the largest public health crisis of our lifetime, what we've seen is that the power of pre-existing coalitions to do things has been spotlighted, and our ability to meet the immediate needs of CHWs on the front line while approaching this crisis as a larger opportunity to advance the cause of CHW professionalization felt relevant not just to our field, but to many other fields as well. During COVID-19, this coalition has played a critical role in mobilizing hundreds of partners to aggregate research, to rapidly produce and disseminate white papers and protocols on the roles and needs of community health workers in the response, and to pool resources for the quantification and procurement of essential supplies. Today, thanks to the platform afforded by the Skoll World Forum, you'll have the opportunity to hear from our team members from East Africa to West Africa about how all of this happens. What are the actual mechanics that allow people from over 40 countries to collaborate on a day-to-day basis and actually get things done? That's what we're here to talk about today. So our objectives today are: one, to share the 5 lessons of radical collaboration that we think are helping to end the COVID-19 crisis, to identify practices from all of this that we think will help prevent the next pandemic, and finally, to invite you to join us, no matter where you're coming from, what your role is, and what field you are participating in. We'll aim to tackle these goals in sequence. Those timestamps are for Pacific time. The slides will be up on the screen kind of throughout the presentation at different points. They'll also be available for download afterwards. Just contact us. And then one housekeeping note before we begin. You'll see that up on that screen, midway through the presentation, we're going to stop and have a rapid fire Q&A session where you ask us your hardest questions about how this actually happens. How do you actually have people who are meaningfully collaborating and engaging and owning things from so many different organizations, so many different time zones, and so many different settings. So it is coming up in 30 minutes, that Q&A, and we do mean it will be rapid fire. So make sure you get your questions in soon. You can just type them into the chat. Without further ado, to give us a more granular view of what's at stake in the COVID crisis and what spurred us to action, I'm really pleased to introduce Uniter Adoyo, Community Health Worker Supervisor working for the Ministry of Health in Kenya and Luala Community Alliance. Uniter.
I'm Uniter Adoyo, working for Health Kenya in collaboration with Luala Community Alliance. I'm a community health worker, just the way Madeline has just said, and I'm happy to join this meeting. And I would also wish to share how we do our activities. Yeah, so with us, the CHWs are being selected and being trained. After the training, we are being given different and specific modules, whereby we are being taught or being given trainings on maternal and child health, the family planning, water, hygiene and sanitation, HIV, and early childhood development. We do all these in the community. And as per this pandemic, the way it came, at some point, it
Uniter, we seem to have lost you.
Sorry?
We just lost you for a second. Do you want to repeat the last couple of things you were saying?
Okay, I was just talking on how the CHWs are being selected, being given trainings on specific modules, whereby they are being trained on the issues of maternal and child health. They are being taught on the family planning. They are being given information and trainings on how to deal with the HIV clients. Even this pandemic of COVID-19, we are being taught on how to do the home-based care. But still, we are having a challenge because of the way the pandemic is moving. And sometimes we get sort of PPEs. Yeah. Thank you.
What's been the biggest challenge during COVID-19 beside getting personal protective equipment?
Yeah, the challenge is that being that the pandemic is there, but still we have to visit these houses and give more education to our people. Being that when the pandemic came, people were not visiting the health facilities as required, but us as CHWs, we still have to give these essential cares to our people in the community. And here is a fact that you may infect or you may be infected by a community member, especially when the PPEs are not there in the community. Yeah. At the same time, the number of houses that we visit are so many. We visit, like one CHW has an average of 70 to 100 houses that are supposed to be visited by this CHW every month. And sometimes you also have priority visits to some houses, whereby you are required to visit an houses for more than one time in a month. So it becomes a challenge for us sometimes. And especially in Kenya here, the government, our government has not recognized so much on the community health workers. They are not being given the salary as required, if I may call it the stipend. Yeah, apart from other NGOs that recognize these people. So that one is a great challenge. Another challenge is on the supervision module of the community health workers. Apart from the supervisors that are above us, but we as CHWs, we don't have our direct supervisors, like maybe a CHW is becoming a supervisor to another CHW that is recognized by our government. So it is also a challenge. Yeah. In relation to COVID, our government, okay, I can say it is trying, but not much. People are really crying that the PPEs are not enough, especially not all the CHWs, all the community health workers in Kenya get the PPEs. Some get, some do not get, and we are at risk. So that one is a major challenge. Yeah, thank you.
Thanks, Uniter. So as you just heard from Uniter, CHWs provide critical care in their community. They travel far distances to reach households that often are unreached by a traditional facility-based care. Now during COVID, they face the extra burden of having to do additional tasks, tracing, whether that's providing home-based care for people who are sick with the virus, whether that's doing vaccines. And on top of all of that, many of them are either unpaid or underpaid, as Uniter said, and not necessarily provided with the protective equipment that keeps them safe. So this is the stage that was set in March of 2020. And I'm really proud to introduce Malika Raghavan, who's the Manager Director, Program Strategy and Performance, Last Mile Health, to tell you about one of the first things we did to begin to meet this challenge.
Thanks, Madeline, and thanks, Uniter. So I wanted to start our first lesson, which is to start now when you collaborate. So one of the things that we were really lucky to have about a year ago was a existing kind of tight-knit network of collaboration and organizations and relationships where we were able to leverage and respond faster than ever to COVID-19 as it relates to community health workers. So at the start of the pandemic, the Community Health Impact Coalition convened actors across both the health and the non-health space to share best practices, lessons learned, bottlenecks and challenges on the best ways to prevent and detect and respond to COVID-19 in real time. Actually, many of you who are on this, who are joining us today, have been part of these sessions for a number of weeks, and we essentially met 20 weeks in a row, and this became a center of gravity for about 100 plus organizations. That included nonprofit organizations, technical organizations, institutions like UNICEF and the World Health Organizations, different donors and funders as well, who collectively and collaboratively helped develop global protocols for how CHW should adjust their services so they're able to provide a continuity of care to their community members, and to think about ways in which to effectively respond to the pandemic at the community level. Our key lesson here is that co-ownership helps drive and solve problems faster. It produces better outputs, it drives uptake, and we're able to learn from one another, not just within the health sector, but outside of the health sector as well. Collaboration like this across many diverse institutions doesn't always happen so organically. So we have felt really fortunate to bring together expertise from, across the globe, and to bring together new innovative approaches at a time in which we all didn't know the answers and needed to solve those together. A few examples that we can highlight that this group kind of produced are things including advocacy materials on the role of community health workers, both during things like training and upskilling of community health workers, how to best ensure that distribution of PPE was prioritized for community health workers, and as we look to kind of vaccine deployment, what is the role that community health workers will play? So just want to say we're grateful for the collaboration of so many of you here, and those meetings continue to happen on a weekly basis as we look forward to the next year, and we hope that you'll join us. So I wanted to pass it over to my colleague, Sarah Malaba, who's the project director for the Strengthening HIV Self-Testing in the Private Sector with PSI. Over to you, Sarah.
Thank you, Malika. And I want to say that I'm joining this conversation because of my previous work with Living Goods and have been part of the SHIC team for more than 30 months. Our biggest lesson number 2 is really around being a team and not a club. Clubs form around shared interests, form around a shared mission. During COVID, the coalition galvanized around the opportunity to amplify the role of community health workers in the COVID response. A lot of that had to do with providing guidance around how to integrate community health workers in the COVID response. And we realized quite early that in order to make progress, we needed to be normative in an evidenced way and cast a vision that others can rally around. And one example of being able to do that is that early on in March of 2020, more than 30 individuals who are part of the coalition collaborated to produce a position paper on prioritizing the role of community health workers in the COVID-19 response. The position paper was written in less than 48 hours and accessed more than 2,000 times in the first 24 hours. Key lessons from that paper continue to help orient the ministries of health and other implementers, including funders, on priority actions. And key among those that we continue to speak about is that we need to protect healthcare workers. We need to interrupt the virus. We need to maintain healthcare services and the surge capacity of those services. And we need to shield the most vulnerable from socioeconomic shocks. This would not have been possible if the coalition moved on as a club. We actually moved on as a team and continue to work together as that very strong team that brings together different expertise and is able to gather rapidly evidence from different country contexts. I now introduce Tom Cole, the Global Health Lead of Crown Family Philanthropies, to speak about the lesson number 3.
Great, thank you, Sarah. Can everyone hear me okay? All right, thank you. I'm a several decade veteran of the humanitarian development space, presently in a position to help leverage resources to where they can most effectively be used. The question is, even with robust collaboration, how do you leverage an idea far greater than any one of the constituent parts? A goal that's bigger than any one of us could have imagined by ourselves. Many of us have operated in a space where showing weakness or lack of capacity or technical expertise can be frowned upon. We're out there to win grants, to win proposals, to show our value in bringing even greater resources to our own organizations. I've been part of it, and I know that's the unfortunate premise of how much of our work operates. What I saw out there, however, was a process that turned this paradigm on its head. As others have mentioned, this began as a weekly gathering to share data and ideas for programmatic and operational responses to COVID-19 in relation to community health workers. The structure was hosted through the Community Health Impact Coalition, though countless other key players fed in. I took part in those weekly meetings along with many of you that engaged dozens of actors, essentially building out in real time the protocols needed to help protect, support, supervise, capacitate, and fundamentally quantify the number of CHWs on the front lines of the COVID-19 pandemic. Building off that monumental quantification exercise, the first of its kind looking specifically at CHWs across sub-Saharan Africa, the question soon morphed from how many CHWs are out there to what do we need to do to reach the numbers we're talking about with adequate protective gear. We realized quickly we were all out of our comfort zone in answering that question adequately. Each week, reports came in from organizations and even individual countries that prices were quickly accelerating, and that these essential protective items were becoming scarce on the global market. PPE was quickly becoming out of reach for those on the front lines who needed it most. The needed guidance and structure of weekly SHEIC-led meetings morphed into a radically participatory exercise that we've talked about already that brought everyone into the discussion in real time. Besides country-specific and local data on numbers, we're continually asking ourselves, how can we really work to protect CHWs? Who to leverage for supply chains? Who to leverage for, who has relationships with all the ministries of health to ensure smooth importation into these different countries? Who to leverage for transport? How to move the product from points of manufacture to each of the countries, and then from the capitals out to the counties and provinces, and ultimately into the hands of CHWs working tirelessly out there at the last mile. The answer was countless organizations, people, entities, and ultimately donors stepped in to make this work. The dysfunction so often rampant in emergency response was replaced by a collective action relatively unknown in this space. Many of us recognized that the need was far greater than any one of us could provide, and that there were others who could reliably and adequately fill the roles that our own organizations could not. And that's not a small feat. The success of CAF Africa to date, with more than 66 million pieces of PPE delivered, pulling on the strengths of the Pandemic Action Network, the Community Health Acceleration Project, Direct Relief, SHEIC, and many others, was that all of these organizations and their strengths were called into action. There was no time not to respond. That sense of commitment, vulnerability, and action were the hallmarks of this incredible effort. So thank you. I'm going to pass this on now for the fourth learning point and I'd like to introduce my colleague, Jennifer Foth, Deputy Director for Living Goods based in Kampala, Uganda. Jen, over to you.
Great, thanks so much, Tom. Just confirming everyone can hear me, okay? Great, okay. Well, I think this fourth lesson is kind of obvious after everything that my colleagues have said, and I think the natural outcome of these three lessons and the implementation of these three lessons by this amazing group. And that lesson is get things done. And that's what SHEIC does. SHEIC gets things done. And I think part of that has to do with the tone that has been set by our fearless leader, Madeline, who from day one, and who only sometimes has to remind us on occasion, that that this group exists to take action. We're not here to be on calls and listen to each other and just sit around. Like, this group exists to action these design principles and to take action on these issues as they come up. So when we get on our fortnightly calls, or when we're putting together these ad hoc calls to collaborate on these pieces of work, we're all bringing our best ideas and we're putting like our sweat equity in. And that's something that we're required to do as part of this group, is really come to the table every day with all we got, the knowledge that we have, the resources that we can bring to the table, from our organization, and really put that to the service of this group and the amazing things that we can accomplish together. And I think that because that expectation has been set from the get-go, this group doesn't show up even when we act to do the bare minimum, right? We show up and we go above and beyond sort of the call of duty, I would say, to get things done. We're always looking to push ourselves further and to think about what the next thing is that we should be advocating for, that we should be pushing for, related to the design principles, related to COVID-19 response, related to, what getting community health workers the support that they need in order to deliver high quality services. I think a good example of this was actually right after one of our first big wins, which is here on the slide, which was, we were able to, through a lot of advocacy, to get 7 out of 8 of our design principles included in the WHO guidelines on health policy and system support to optimize community health worker programs. And that was a big accomplishment. And I think a lot of people would have, patted themselves on the back and said, that's great and well done, team. this team sort of was like, great, what's next? And rolled up their sleeves and, we're looking to WHA 2019 and said, okay, how do we get an endorsement from WHA? How can we get member states to sign on to this and really officially endorse these guidelines and these principles for community health? So I was fortunate enough to be at WHA that year, and I very distinctly remember being, in a side meeting or a conversation with another partner, and seeing Madeline and seeing Jenny and seeing other team members just running by me to get to the session where they were going to be advocating for this, member state sort of motion to formalize the community health guidelines. And I think that just encapsulates it all for me, that even when we're in the midst of, our own organizations and trying to, serve our own interests at WHA, we're still making time for this group and for the interests of this group and for the interests of community health workers at large, and putting as much effort into that as we do for our own individual organizations and scopes of work. And I think it's because this group goes that extra mile and commits to putting in that sweat equity, outside of our regular calls. And I think that's one of the reasons that we get stuff done. It's what allowed us to develop the priorities for the COVID-19 response paper. It's what allowed us to get, CAF up and running and off the ground. And it's ultimately what led UNICEF to engage us, to proactively engage Chic to create these WHO guidelines on the roles of community health workers in the COVID-19 vaccination response. So I think, when all of these other lessons are in your DNA, when sweat equity is in your DNA, you have no choice but to get things done. And I think it's just the natural outcome of adhering to these lessons and these principles as a group. And that's the result that you get. So before we introduce the fifth and final lesson, I want to hand it over to my colleague, Jennifer Schuchter, who's the CEO of Integrate Health, who's going to take your rapid fire questions, which I see are rapidly coming in on the chat box. So Jen, we'll hand it over to you to facilitate that discussion.
Thank you, Jen. Hi, everybody. This is the time when we turn it over to you. We thought in planning this session that we always work so hard to tout all of our amazing successes, but could we also push ourselves to maybe expose a little bit of the challenges and, dare I even say, failures? So we wanted to turn it over to you to ask us your hardest questions, challenge us, and we'll do our best to be radically transparent with you. So I'm going to start with a few of the questions that came in through the chat. I see they are rapidly coming, so we'll try to get through as many as we can here. We have just about 20 minutes. So I want to start with a great question that came in from Pascal. Pascal asks, how did you manage to get UN agencies and bingos, by bingos she means big international NGOs, to join in and collaborate with Chic? I love this question. Sarah, maybe I could ask you to start and weigh in with your thoughts on this question.
Great. Maybe in the light of I can just fall back into what we had and how we included those. I think when I talked about being a team and not a club, most of that had to do with the fact that some of the partnerships that we were able to pull in were really organic. And they were based on what we thought was best for the sector and what different institutions could bring, including our members who are able to pull into their networks and coalitions other than the Chic one, to be able to bring on board technical expertise that enabled the write-ups that you saw we've flashed out by Jen and the rest of my colleagues. I think the other way was that once we got something going, and Chic being a doer and not just a talker, we had a lot of bi-multilaterals reach out and ask questions and say, hey, could you think about XYZ in as far as community health is concerned? So it goes to say that if you put your hands on the deck, if you get your hands dirty, and others think that you're movers rather than speakers only or talkers only, and see that you're geared towards doing action, everybody wants to join an actor, and not just any actor, but an actor that catalyzes responses across the globe, as it was with all the guidance that we were able to get out and all the data that the coalition was able to pull and share quite quickly. So that is how I would respond to that question based on our experience in the past 1 year.
That's great. Thank you, Sarah. And if anyone else on the panel wants to jump in on a particular question, just feel free to jump on in. You know, I think there's a little bit of a, if you build it, they will come. And in this case, Chic has really proven to fill a void. And so organizations like UNICEF will turn to us when they get done really quickly. We've seen that, and it's been quite remarkable. Maybe I'll join two questions together here now. Bart had a question about how can we start leveraging more open source digital production technologies to create local and resistant supply chains over time that can be adapted for a circular economy. Actually, that's pretty specific to supply chain. So maybe we'll start with that one first, and then I'll jump to the other tech question. Anybody on the panel want to tackle that? If not, we may be able to call on a few audience members. I think we have Melissa, maybe from Village Reach, if you want to jump in on that one, another Chic member. Okay, I'll give it, we'll circle back to that one because we may have some tech challenges getting there, but I'll jump to another tech question from Catherine, which was, if we were to narrow in on one of these lessons for tech industry partners in particular, what lesson would we highlight, or would there be an additional call to action? Anybody want to jump on that one? Malika, can I turn that over to you?
I think, you know, I think that what's probably been highlighted here is a lot of these lessons are quite linked to one another. So I think that, you know, we recognize this as Chic, and you'll see from our membership that we're not just a set of community health implementing organizations, but we actually have leaders and expertise and organizations who bring a lot of the other aspects of what drives really strong community health systems design. Everyone from, you know, our partners at Village Reach who bring supply chain expertise to our colleagues from Demagi to Medic Mobile who bring kind of digital health expertise to so many others who are really helping leverage what an integrated community health system looks like. And so I would say one of the more unique things is that when we started the Community Health Impact Coalition to where we are, we've grown into kind of diversifying our membership with the recognition that it takes a village to create the kind of systems transformation that we want to see. And so I think kind of lesson one in terms of kind of starting now and kind of casting the net wide, as well as being a team and not a club, and really being open to that level of diverse membership is really important. But I would also say, I think we recognize that there are areas where we may not be as strong, where we need to leverage other folks from digital health or supply chain. Scouting our own weaknesses means that as we continue to do our work as Chic, whether it's during the pandemic or not, I think we continue to have honest conversations about where we need to bring in other new ideas, new innovations, new streams of thinking. And I think that's an area where technology and the actors within this space can continue to play a role.
That's great. Thanks, Malika. Tom, this next question is for you, so you can get ready. We have a question from Keisha, which says that, as you mentioned, current funding models often foster more competition than collaboration. So how can philanthropies and grant-making organizations themselves also change the dynamic model, help to incentivize more efforts like what we've seen with Chic?
Great, thank you. Thank you, Keisha. Thanks for this question. I think as donors, it's time for us to really to sort of step back into the background and really listen to what the needs are on, not just needs on the ground in terms of, doing services and materials on the ground, but I mean, what's very clear to me here in this conversation, in this exercise, is that people want to collaborate. And oftentimes, there's ways as donors we can do that that's maybe non-monetary. We can help network. We can help set things up behind the scenes for you all to do the work. You're the experts. We're not the experts in that. And I think really as donors and grant makers, it's really about listening to those voices on the ground and saying, okay, what can we do to help provide that? And really then just step back. I would say that's a key lesson for me moving forward. Thank you.
Thanks, Tom. That's great. And maybe building on that, I'll just highlight another question here from Julia, which asks, as a funder, how can we address the inherent power dynamic between grantee partners and funders when seeking to form collaborative coalitions? And I think building on what you said, Tom, that really rings true in our experience as Chic. You know, there were a group of funders that helped to seed and form Chic at the beginning, and they were very conscious about not participating in the group. They helped to get it started and seeded and off the ground, but then actively chose to step back and allow us to have the conversations among ourselves. They were available and willing to jump in and be called upon as needed. But I think we made the smart decision very early on to engage a formal leader in Madeline. And once that was put in place, then the funders were able to step back. So I just want to echo that. And I think that's a really good way to address those power dynamics. We had a great question come in around government. So I want to make sure we speak to this because I know we all work very closely with governments, and Chic prides itself on really working to strengthen existing government systems. So Betsy's question was, how is Chic working with local governments, and who is representing government in the coalition at the global and national level? Julius, maybe I could turn it over to you to share some thoughts.
Yeah, thanks, Jennifer. To reintroduce myself later, I'm Julius Bear from Luala. I'm co-CEO, and that's a great question on how Chic and the network is working with governments. And actually one of the things that I wanted to point out in our experience in response to the pandemic. Number one is a recognition in Chic that community health is part of the public health system, and there is no way we can excel in delivery of healthcare services at community level without involvement of government. So in country, organizations that are part of this collaborative engage very closely with the Ministry of Health. In Kenya right now, we are building a network called Community Health that is actually to have the government or Ministry of Health as part of the secretariat and it just goes on to say that every effort needs to include the Ministry of Health, because we are talking about the system and system change, and there is no way you can change that system without having the people who are running the system part of this. So we have deliberate efforts of having Ministry of Health representatives in our collaboration, and also including them in engagements that we have with the likes of WHO and other international engagements. And whereas we do not have formal membership of government representatives in Chic, it is a given that all and most of the organizations are actually working through the relevant departments of the Ministry of Health, and having the Ministry of Health as a collaborator and a partner in everything that we are doing. Thank you.
Thanks, Julius.
I had just one thing on that as well. I think part of the collaboration as well is really bringing in the government on these design principles and working with government to action these design principles. And the AIM assessment, which I'm sure you guys have heard about or will hear more about after this, but basically a tool to assess sort of where is a community health program with regards to, its maturity and sort of, how it scores along these different design principles. I know my colleague Sarah, when she was with Living Goods in Kenya, did a ton of work on, working with county governments and the national government to go through this assessment, to assess the community health worker program based on these, these key metrics, and use that as the launching point to drive, not only the work that they were going to do in county, but also national strategies. Same process in Sierra Leone. I'm supporting our team in Burkina Faso. We've done a very similar exercise there. And I know that, for Integrate, it was a big thing getting the government to sign on to this, and actually crowdsourcing a lot of chic to translate those materials into French as quickly as possible. So I think, government is a key partner for us also in terms of when we think about how do we scale the design principles and the AIM tool, and how do we get this, part of the routine planning and design processes for governments as well. So I think that's also a key way in which we engage governments and really want to make sure that it's a collaborative effort to scale these principles.
Absolutely. Thank you, Jen. We had a couple questions that just go right to logistics. How did we make this happen across so many countries and time zones? So let's see, we had one question here from Julia from a logistical perspective. How did we navigate multiple time zones, varying internet connectivity, and difference in languages? This question gets to my heart, Julia, because I'm usually the first one that says every day, great idea, is that available in French? Oh, is that resource in French? Oh, is that panel going to have translation available in French? I hope this panel has translation available as we speak. But does anybody want to add on to that question about, just from a logistics perspective, how did we manage all this?
Google Drive.
Madeline, shout out to Google. Madeline, do you want to take a stab?
Thanks, Jenny. So it is ambitious. There are 13 time zones in the coalition, which means someone's always staying up late or getting up really early. And we try to shift that burden. Every year we do a survey about what time we should be meeting. And we have changed time several times. We take a lot of advantage of online collaboration tools like Google Suite effectively, and which enables everybody to, rather than doing version control with 40 people, that's not a thing. It enables everybody to really write together in real time. And we've had a lot of success. The paper that Sarah mentioned was written that way. And nobody believes us when we submit things to, Think Global Health or a journal that there's actually 30 authors, but I can show you the edit history of these papers, and everyone truly is writing and collaborating and able to do it on their time. So, Rahan in Pakistan is able to write something, and then the next morning Ari in California is able to wake up and see it, and it just, the work almost never stops. We have folks who speak a huge number of languages in the coalition, and we have active working groups in English and French. Most of what we're doing is still in English. That is a barrier. But again, we try to at least make everything that we do as a priority that was really spearheaded by Jenny, available in at least 3 languages, English, French, Spanish. You'll see that on the website. Every single resource we put out is simultaneously translated into all of those. And then we try to put an emphasis on becoming a dense network. So rather than the Secretariat just kind of making things, producing things and asking for consultations, we try to foster in our fortnightly meetings. That's kind of the hub of how we collaborate. Every 2 weeks, we're all on the phone at the same time for at least an hour. Opportunities in each of those meetings for folks to just honestly talk to someone that they don't necessarily know very well for 10 minutes. And there are so many good collaborations and relationships that come out of that. And as a Secretariat, we also meet one-on-one at least 3 times a year with every single organization to get the real dirt on what's going well, what could be improved, and what we should be doing next. And I want to thank actually Phyllis Height, who's in the audience now. When we started the coalition, she suggested we have these one-on-one meetings, and I said, "What's the point of that? That seems so silly." And she knew something that I didn't know at that time, which is that it's relationships that drive work. And the more people feel like they're connected and they trust each other, the more that they can engage in unfiltered conflict around ideas, and the more that they can commit to shared plans of action together. So that's been really essential for us.
Awesome. Thank you, Madeline. And I think you actually in here, which came in from Eileen, about how much of our communication is informal versus formal. I think Madeline really explained very well that it's a combination of both. So we have our twice monthly meetings, which is a formal time, but then we're constantly engaging, co-editing, collaborating, sharing ideas back and forth offline. So it's very much a combination of the two. I'm going to go rogue here for a second because I have the mic, and ask a question that I want to ask. And I also want to bring in my colleague Uniter here. So Uniter, I would love to ask you, what does it mean to you to know that Loala Community Alliance and you are part of this global network? What does it mean to you to be part of Chic and to know that you're part of a global movement advocating for community health workers like you? Could you share some of your thoughts? Uniter, I believe you're still on mute. So if you just click your microphone so we can hear you. Let me see if I can there we go.
Okay, concerning the question that you asked, I think it is just good because it's promoting us as CHWs. I feel good when I'm here to join in the conference. So like other CHWs would also love to be the way I am today. Yeah, it's quite great. Thank you.
Well, it's a privilege for us to have you here. So thank you for making the time. I think we have time maybe for one or two more questions. We had an interesting question come in here from Ben about who isn't on the team and why, or are there competing teams? Does anybody want to share some thoughts on that one?
Whoever is not on the team is actually missing out. I would say they need to catch virus FOMO, fear of missing out. And really, this is an open plan, an open club, constantly reviewing and admitting members, and everybody comes with a value add that we so much believe in. And I think it's an overreach to imagine that everyone in the global health space can actually be part of SHIC. But I do believe that everybody who can be able to join and make a contribution is joining a great team that can actually move the needle in terms of professionalizing community health services and ensuring that communities and individuals that might go a lifetime without seeing a doctor have the opportunity to get a health worker within their reach.
Thank you, Julius. Let's see, I think maybe we'll end it on this one good and challenging one from Aaron. Which principle required the most arm wrestling among members and why? And if there were any impasses, how did we overcome them? Anybody feel, I'm trying to rack my brain and remember when we argued the most. We certainly do argue from time to time.
Point of care user fees. There's a lot of evidence about how point of care user fees decrease access to care. We also had members who were doing amazing work selling commodities in communities. And so how did we balance the fact that, how do we make sure that essential commodities were available for free while also giving folks around the world the chance to access stuff that wasn't necessarily available to them via other means, and that could be life-saving or life-enhancing in themselves. And so getting the language just right and thoughtful on that was a big thing when we launched, and getting, solidifying these 8 principles. And it required a lot of, but have you read this study? Have you read this study? Have you read this study? Back and forth and back and forth. But the point is that there was a dialogue. And I think that there was a lot of learning across the different members of like, well, how does this help you do better management? Well, how does this help you increase access? And how do we take both forward and solidify these different areas of expertise into ultimately what our advocacy agenda was gonna be. So yeah, not shying away from the big issues, but trying to come forward with something that's constructive, just to Sarah's point, normative, evidence-based, and also not mealy-mouthed, that really says something. And it's not always an easy process. or it certainly wasn't at the beginning.
Thank you, Matt. Well, I think that's a great place to end it, because it is true and honest, and we do argue and push each other. And I always feel, coming away from my interactions with my fellow members at SHIC, that I've learned something new, that my thinking has been challenged. And I often cite back to those conversations when I'm explaining things to others outside of the coalition. So thank you all for your questions. This was awesome. At this point, I now have the great privilege to introduce Julius Mbea, who is the co-CEO of Loala Community Alliance, who is going to share with us our final lesson and implications for what this all means and what comes next. So over to you, Julius.
Thank you so much, Jennifer. You know, really, to say the least, 2020 and this pandemic has been hard on community health and the health community globally, and much more so in areas and communities that do not have access to the care that would be desired in a pandemic like this. But I'm also encouraged by the fact that there is a silver lining behind every dark cloud. And what we have seen through this collaboration is the power of organizations and individuals coming together to think through together and to take action together. This collaboration and radical collaboration, as you call it, authored a blueprint for response to COVID-19. The 4-point agenda that was highlighted by colleagues here, you know, stopping the spread of the virus, protecting healthcare workers, maintaining essential services while surging their capacity, and protecting the most socioeconomic impacts of COVID-19. Those things have continued to guide responses around the globe, and has been a blueprint that organizations have been able to look into and to design their responses accordingly. The collaboration also has enabled us as members of this coalition to be able to engage even more deeply with one another, both at the country level and globally. And I believe that this is an opportunity for us to continue growing that, and to be at a position where in pandemics like this, we do not look to our individual organizations, but we look at the collective strength that comes from working together. I can see, say for example, in Kenya, we've been able to support the Ministry of Health in developing guidelines and protocols that went on to improve on the work that community health workers are doing. In certain instances, we had cases of community health workers being withdrawn from the front lines. UNITA mentioned to you that PPE is not available for all community health workers across the country. And that is true, not just in Kenya, but across the globe. But we also knew that COVID-19, as and by itself, was actually not going to hurt as many people as other common illnesses, malaria, pneumonia, the work that community health workers do every day in saving lives and increasing survival for under 5 children. So we had to act fast, and you've heard from colleagues here that we are all about action. And part of that action was actually authoring guidelines that the Ministry of Health depended on, so that community health workers can get back to work in a safe environment and in a way that do not hurt or expose them to risk. Now, we all know that COVID-19 did not end in 2020. Actually, as I'm speaking to you right now, Kenya is in another round of lockdown, which means that we'll continue to experience wave after wave of COVID-19. Some of those waves will become more deadly, as is the case right now. And so that means that we need to continue working and responding to this pandemic. We need to harness the lessons that we've learned through this response to buttress the health system. I think the biggest lesson that we can have as a collective is that it is the things that we learn through crises like this that goes on to strengthening health systems. And as a collective, we are that we take the lessons from here to ensure that in respective countries where we work, that community health workers get the recognition that they desire, that the payment that is so needed to ensure that these health workforce is rewarded for the risky and tireless work that they do, that the supervision is appropriate, and all the sentiments and elements of community health system strengthening that we all talk about. We also know that in response to the pandemic, PPE will still be required. We need to invest in availing PPE for community health workers. Through SHAKE and collaborations with other partners, efforts like COVID Action Fund for Africa has managed to deliver millions of PPE to community health workers. That effort needs to continue so that community health workers can continue to provide essential services to households while at the same time remaining safe and secure even as they deliver those services. We've also been lucky to get vaccines in record time. We need to place community health workers at the front of the queue, ensuring that even as countries are making estimates for vaccination, community health workers are part of those estimates. And when the vaccines become available, that they are at the front of the queue and are not sidelined in the distribution of the vaccine. Community health workers will continue to play an important role, including tackling vaccine hesitancy and providing ongoing healthcare services. And so it is in this light that I call upon all of us to join this effort in ensuring that this radical collaboration that has so far been demonstrated here can not only expand, but can go on to change health systems for the good. So please join us. We have a website, www.chik/impact coalition.org. And if you want more information on how you can get in touch with this radical collaboration, Madeline will be able to put the email up there. It was already in the chat. But thank you so much and really appreciate your support. And we invite you to join us in this radical collaboration. Thank you very much.